Welcome to Reimagining Your Command Center Strategy. Thank you so much for joining us today. Before we get started, I would like to go over a few housekeeping items. You can submit any questions throughout today's session in the Q&A box on your dashboard. Today's session is being recorded and will be available after the event. If at any time you don't see your slides moving or have any trouble with audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. Lastly, you'll find a few other engagement tools on your dashboard. Be sure to check out our resources section and fill out our event survey. At this time, it is my pleasure to begin today's program by introducing today's speakers. We have Jason Harber, who is Vice President of Client Services here at LeanTaaS, and we have Bill Griffith, who is our Operational Excellence Lead. Thank you so much for being here, guys, and I'll turn the floor over to you.
Hi, everyone. Thanks for joining us today. If you're not familiar about LeanTaaS, the one thing to know about us is we are a Silicon Valley and Charlotte and Boston-based company that focuses purely on using math to optimize capacity inside of health systems. We've invested over $350 million in the software that we'll talk about today with the pure purpose of making sure that we can unlock capacity inside of health systems and make everyone more efficient and effective, ultimately leading to better care and more accessible care for our communities. Now, we've done work with so many organizations across the country, as you can see by the numbers here. And today we're here to talk about the very big issue of inpatient flow. And if you think about, inpatient flow, the problems are more prevalent than ever. And as you heard in the intro, it wasn't often, and even now, people are thinking, well, if I build a command center, I can solve these problems. No more long wait times, no more staffing issues, throughput, magically is optimized. And, the reality is the old view of a command center, if we all closed our eyes right now and just thought of a command center, we would see a room with screens on a wall. And the centralization that's been done over the past decade or more has been a fantastic movement inside of every health system that's done it. But the reality is that this top-down structure only solves part of the problem. The reality in how you work every day is it's very distributed and it's very disjointed and asynchronous in the way that, say, a local hospital is prioritizing how they discharge patients, and that centralized command center is operating day to day. So it's our vision at LeanTaaS to bring a new way of thinking, a hybrid way of operating, bringing both the best of centralization and day-to-day operations together in a digital automated platform. Now, to make this happen, and because of the expertise that's required, we believe it takes a very unique formula to accomplish this goal. Obviously, the first is we need real-time and predictive analytics about everything that's going on inside of a health system. And that's not enough, though. Even if we have great data and even predictive data, we need to be able to automate interactions across a highly distributed network. Now, the software you'll see today does just that. But to go beyond that and to really change the culture of an organization, change management is so important. So what you'll find today, even hearing from me, who's been working on patient flow for over 20 years, or Bill Griffith, who's joined me today, that it takes experts, partners to work with you, arm in arm, developing strategies and deploying strategies, not just for an implementation, but for the life and the journey that you'll be on as a health system, ultimately leading to all that great value that we hope to unlock by, obviously decreasing our length of stay, optimizing our staffing, and, creating frictionless experiences for our patients. All of that requires all three elements that we just talked about. Now, when we work with an organization, there are a couple key elements to know about as you look to kind of modernize this idea of a command center. The first is, we must have governance to change the way we work. And, we'll come into any organization and talk to you about, what does a governance team mean to operate at a system level, but also have local influence. And once we're able to do that, we'll be able to mobilize across a couple key topics. First, there's the role of your transfer center or placement center. They're a great function. They're an important, critical department inside of your organization. What's the future state, definition of that centralized function? And then we'll be able to move across thinking about how we hardwire, specific practices around capacity management, discharge planning, and staffing. And when we do this and follow this playbook, we see great results. And, throughout Transform, you'll likely hear from clients, but you'll see that whether you're Sarasota Memorial in a booming market in Sarasota, Florida, or your UC Health with a large academic health system in Colorado, you are able to scale inpatient flow and coordinate inpatient flow using digital systems at both a centralized and decentralized way. Now, let's really talk about how it happens. Now, if we were to think about how we manage flow today in an organization, obviously, there's things happen centralized and decentralized. But in each of the core areas that we've talked about so far, you'll actually find very manual process inside of most organizations, nearly all organizations across the country. The first is, how do we do capacity management? And by capacity management, we mean aligning supply and demand every single day. The reality is, when you dig into your organization, there are probably some impressive spreadsheets that exist that create a more of a 360 view of your operations. What's the census on every unit? How many OR cases do we have going today? What's the ED look like, et cetera? Maybe even we use that spreadsheet in a bed huddle. We use some digital systems, but then they don't end up having all the information, but we keep falling back to the spreadsheet. Now, if we dig even deeper and go into an individual department like the ED likely has their own spreadsheet. Maybe they're doing an EDOCS calculation or other things. And before you know it, we have multiple sources of truth, digital systems, manual systems, and multiple manual systems across departments, all tracking supply and demand. Then we go into our discharge practices, where we have yet another set of highly manual processes. We have, poor, accountability on our discharge date targets, and maybe just even poor compliance. We have unknown barriers constantly happening, the coordination across teams, and even the awareness across teams, whether I'm nursing, case management, an ancillary department, maybe even a hospitalist group. We all don't necessarily have the same playbook. We don't know the same priorities. We don't know which units are more important than others. And yet again, we're working on manual process, phone calls and coordinations and heroics to make things happen. When we dig into staffing, the spreadsheet rears its head again. So if you work in staffing, and for one of our most critical resources inside of an organization today, being our nurses, our day-to-day staffing happens yet again with spreadsheets and phone calls. The spreadsheets that most organizations use are impressive, right? We're trying to figure out, I know what the schedule says, but how many people are actually working? And once we actually know that, how do we get a balancing act and get to truth on where we're going to put our float pools? And there's phone calls, huddles, et cetera, huge amounts of effort for every one of our nursing leaders, only to give us very little time to focus on the future, where most of our staffing issues actually exist, where people are concerned about premium pay and other issues that are hindering our finances. So as we look at these three issues, obviously, performance measurement and just understanding improvement opportunities in all of these is very hard. So, and having the governance structure to do that is, quite an effort for most organizations. Now, if we think about how we can solve this problem, And by creating a more distributed, not just centralized mode of a command center, is we need to mobilize the data. And if we think first back to where most organizations are today, and we're using standard dashboards, the dashboard really is one, just to be clear, it is a great performance improvement tool, right? Visual management is a known performance improvement tool. But what it really does is it only helps us admire the problem. And we've all been there. So if I'm sitting in one of your organizations today, wow, our census is high, right? Look how many patients we have in the ED. But what do we do about it? So we're going to add two elements to take us beyond that simple visualization. The first are predictions. Inside of your future state command center, it needs to be predictive. It needs to be able to see the future and guide the organization in a new way. Those predictions will vary. Some will be macro predictions about volume. Some will be micro predictions about individual patients or activities. A few examples of that will be census forecasts, so we understand the utilization of our beds. They also help understand the utilization of our staff. When are we over or understaffed? When we go down to a patient level, we need to know not only our length of stay targets, how long is this patient actually going to be here, but what are the predicted barriers to be in our way? For example, a missing test, or somebody needing a post-acute bed, around the corner. We need what the predictions really give our frontline leaders are the time and insight to make a decision. But if we stop just with the prediction, we're still forced to act manually. We're still forced to use extra effort to connect across this distributed network that makes up a health system. So the final step of the equation is automation. And automation is the core element of creating this digital network across your system. When there is a bottleneck inside of your organization, let's make sure the teams know. Now, just because we're letting the teams know, the messages to each one of those team members will be different. If we have a discharge barrier, let's automatically identify and get it assigned. Notify that person that they're the barrier to discharge. And in each one of these examples, we create more natural connectedness, collaboration, and remove the variability from your operations. Now, to give you a few examples of this, we're going to do two things. One, I'm going to walk you through a few examples of how the technology looks, feels, and mobilizes an organization. And then Bill's going to jump in and show us a real life example, somebody who had just adopted the technology to show how this transformation not only connects to the traditional sense of a command center, but then creates this distributed connectedness across an organization. So first, let's look at that capacity management practice. So here you have it, that traditional dashboard, right? The dark screens, the mission control look and feel that allows us to track status, have that 360 view of a health system. Now, what you can see, though, is pay close attention to the phone that sits in front of it. Instead of having to read this dashboard and any number of metrics that may be on it, we can actually have the system read it for you based on your policies, your procedures. When we can predict a surge and identify an issue, we can communicate that out to an individual leader, a set of leaders, or an entire team. And what this allows you to do is have 24/7, 365 coverage and standardization of your capacity management plans inside of your health system. You can imagine that this is tracking, if you have today, many organizations may have, we're code red, we're code yellow, we're code black. I've heard better colors like lavender, et cetera, right? That people use, say whatever colors you may like to have inside of your organization. But the reality of that is it requires people monitoring multiple data points and actually being able to coordinate and collaborate across the organization. Many times those capacity management plans get drafted and then sit, kind of in a dusty pile or a dusty digital pile. Now the software manages the process for you every single time. not only allowing you to see it in real time, but also see it in advance. Now, ultimately, what that process is going to do is it's going to allow us to make sure that our supply and demand are balanced. We're going to know when we may have excessive wait times, and we're going to be able to balance the organization and prioritize the organization. For long-term improvement, we're going to have to go a step deeper. And we all know, I think for everybody, I feel that in 2023, length of stay improvement and discharge planning improvement has been a hot topic, across, the people I know inside of the industry, that we can really drive big change by focusing on discharges. And inside of a command center model, we need to figure out how to connect centralized operations to both the highly distributed day-to-day operations that actually discharge a patient. And Bill will give you a few examples of how we actually recommend that in a bit. But a tool set that helps you mobilize is one that helps you create very segmented discharge priorities across the organization. Know exactly who's going home, who's likely to go home today, tomorrow, et cetera. Who did we miss yesterday? Be able to predict the length of stay targets and barriers, and give people a tool that, whether I'm in the command center or I'm on a floor or I'm in an ancillary department, that will walk with me, move with me, tablet, mobile phone, et cetera, to help move these patients through the system. Now, ultimately, for your teams working on discharge planning, you know that they're going to be working in your EHR and other systems. So we need to make sure that when we need them to step up in the patient flow process, that they are simply nudged and can acknowledge the fact that it's time for them to take action. So the great example that we have in front of us is when we have a patient who can go home. It's not a complex discharge. It's one of our easier discharges. And we need somebody to take action because they've been waiting too long. And this is a simple nudge that can go out via email. This is an SMS, acknowledgement. It could also be through secure messaging, through the secure messaging platforms that you may use today, and simply tell someone what they need to do and what they need to prioritize. This same, recipe of action can be used across, different departments. Obviously, if say you were there was a testing barrier on the day of discharge, or, other activities, the same sequence can be really to remove delays from the system. So then we can really focus on length of stay standardization and, getting the system operating at a much higher level. Now, as we're moving those patients through the system, we absolutely need to care for those systems. And one of the things that we've seen as people have expanded their definition of a command center is staffing being connected to it. And that happens in two forms. We have many clients who choose to actually physically locate their staffing and traditional command center functions like patient placement, transfer center, et cetera, in the same location. But it can also happen digitally, where you may already have a system level staffing office and other functions that exist in another location, but now we can share and understand the data at scale across the health system. Now, in this example, we are able to not only see all of your patient data, but we're also consuming all of your workforce management data as well. So if you're a UKG user, maybe you're a API user, or maybe even ClairVia or other systems, we're consuming that data to build not only a real-time view of nurse staffing across the organization, but also a predicted view. So we know not only what staff we have available, for the upcoming shift, but what staff we may even need 3, 5, 7 days in advance, even up to 8 weeks in advance. And what this allows us to do is not only visualize the needs, but also automate the coordination from unit to staffing office of what the actual needs are. Who called off? What do you need? Do you have sitter requirements, or do you have high acuity patients, et cetera, all to one centralized source without a single phone call. And by doing that, what it allows us to do is give complete transparency, even if we want to see very specific things like like this little kind of icon you see right here, maybe showing me where an orientee exists that we didn't know wasn't in our counts, but we know there's an extra person on that unit today, to make very balanced decisions on where people go every day. And the great thing about focusing on the staffing process and getting this right and getting this improved is, I think we would all agree that the outcomes of getting our nurses in the right place at the right time are endless. And you'll not only see them in efficiency of your staffing office and your nursing leaders, you'll see it in all of your core KPIs, whether it's your throughput KPIs, your quality measurements, et cetera. Now, finally, when we go through this process, one of the most important things to do is have a sense of purpose on how your KPIs will move. So within the technology, while all of this day-to-day operations is occurring, we are monitoring and measuring the KPIs we expect to move. And I think as you hear Bill talk about a client experience, you understand that the KPIs are such a focus. We want to create a great experience for the staff, make the work easier. But as we're doing that, we're reducing variability, and we want to track our progress, but we also want to be able to celebrate the wins. So whether it's your ED performance, your inpatient performance, specific to length of stay or discharge planning, any one of those, metrics all tracked inside of the platform. So you can receive not just visual feedback where you could read a report, but even automated feedback to say, we have finally hit our mark, celebrate the fact that our teams have reached a new level of performance. And that can go to not only your governance team, but could go to all of your frontline leaders that have worked so hard to create better patient flow inside of the organization. Now, with that, I'm going to hand it over to Bill to talk about how we take that conceptual approach that I just outlined and apply it in real life inside of a health system. So if you don't know Bill Griffith, Bill has over 20 years of process improvement experience, both within healthcare and outside of healthcare. He actually had done work at Pella Windows and Tyson Foods, and has over 15 years of experience in managing and building command centers on the health system side and on the vendor side. So if you think about, if there was anyone in the world that, could speak to the evolution that's occurred from when we were first just deciding to place patients or transfer patients to now where we need to coordinate all patient flow in different ways, it's Bill. And I'm lucky to work with him, and I'm excited for you to hear from him today. So Bill, why don't you take it away?
Thanks, Jason. I'm excited to share with everyone. This is one of our recent clients who's done some amazing work. If you don't know, Baptist Health in Arkansas is a very large health system. They have many awards. There's 11 hospitals across Arkansas. They have very strong vision from the senior leadership team on what they want to do. And part of that was building out a command center that they have started working on. And they also have a belief that technology will help support them in this transition, both from a people standpoint, but also a process and outcome standpoint. With Baptist, they came to us with a couple major concerns or issues. One is they were losing over 100 transfers a month. They had long length of stay across multiple campuses. And they also had a decentralized staffing process, which we've been able to help them restructure and build out, which you'll see here in just a few minutes. So I'm going to walk you through kind of the 5 steps that Jason highlighted earlier, and specifically how Baptist approached this. We did partner with them for about the last 6 months to build this out. So we worked with them building out this governance team. This team was led by their system COO, who's now the president at the North Little Rock campus. We had the system CNO, the director from the command center, case management, and then a couple of people from their IT side around integrations and files and getting things from Epic, which is their current EMR. We also set up a weekly meeting with them to go through and start building out the strategy and keeping the project in line. And we continue those weekly meetings today post go live. Next, we work with their director for the command center and talking about how to build out their command center and what does it look like. They already had the space allocated, but they're looking to make it a true command center. So we worked with Greg to form the process, design the teams to be in there. They have recently added a discharge expediter, and her role is to partner with case management across the hospitals and be that resource that can help with discharge management, both for those simple discharges and escalations, but also those complex discharges, whether it be transportation, authorization, DME, or other things that's needed. We also have a space allocated for centralized staffing, which will be in the command center very soon. We are working with the team to build out protocols that will spread across the organization to multiple hospitals. And then finally, their next step is to centralize their bed placement within the command center in the very near future. Third on the list was looking at their capacity process. So we worked with them very closely on their current protocols. We made suggestions on how to improve those protocols. And then we rolled out real-time predictive automated protocols for the organization. Those protocols include ED self-decompression, diversion alerts and analysis, PACU capacity, ICU, med-surg, and then we built one specifically for the command center to look at system-wide capacity so they could see across all of their campuses and figure out if there's a hospital that's in stress, how do we unload that stress for them and move it to a different hospital. We continue to fine-tune those alerts and are working with them now to even escalate and make them a little tighter so that it's easier for the operation to see the current performances. Fourth on the list you saw was working on discharge planning. So we worked with the nursing team and case management, and we built out an escalation process along with a process to identify patients going to their discharge lounge. Both hospitals have a discharge lounge. Our system is automatically identifying those patients that meet the criteria that they use at both campuses, and those patients are identified in the system, and nursing automatically knows that the patient can be taken to the discharge lounge when they're ready for their discharge. As Jason mentioned with the automation, one of the things we have done is built an escalation process. So when a patient is going home with no needs or a simpler discharge, and they've been there more than 60 minutes, we are alerting the nurse manager via their text message that a patient in room 423 has been there more than 60 minutes. You might need to assist, or something is going on where you need to provide additional services. If that continues and goes past 120 minutes, we are then escalating it to the director and also our discharge expediter in the command center. So they can also reach out and provide support or services and get additional resources there as needed. You will see here in a couple more slides some of the benefits we've already seen from this improvement with this escalation. And finally, along the lines of this, we've built some prioritization for both, say, therapies such as PT, OT, and speech, and also radiology services. So they can see which patients are planning to go home, which ones have active discharges, not only for today, but they're also looking at tomorrow's schedule. So we can then prioritize those to get those done earlier in the day to make sure the patients are ready for that rounding with the physician and the case management team, so we can make active decisions based on those discharges. And last step of the process was centralized staffing. So as I mentioned, they have allocated a space within their command center. The team will be located there, and we'll be doing staffing for the entire health system from that location. They did relocate or allocate, FTEs from the hospital. So this was not a new FTE build. This was just a consolidation of current FTEs into a centralized location. With the platform, they're going to be able to coordinate all the staffing from across the hospitals. They're going to eliminate many phone calls and manual spreadsheets that were happening across the system, and also be able to centralize the call-in process, standardize that process, and make sure the whole system knows when somebody is called out and what the plan is to backfill that position. Finally, with the patient flow, they have a census forecast, as Jason mentioned, looking out up to 8 weeks. So as they're doing the staffing going forward, they have better information, and they have details onto the census, not only at the hospital level, but all the way down to the unit level, to adjust those staffing based upon true census and what their plans will be going forward. So these were some of the goals that Baptist has shared with us from the very beginning. Again, it was to build out their command center and make it the hub of all patient flow and staffing across the organization. They wanted to capture those transfers they were losing. And then from a length of stay standpoint, they had two goals. One for Little Rock was to be less than 5.2, and North Little Rock was to be less than 3.8 days. So this is after the first month of going live with the platform and rolling out everything I just shared with you previous slides. At North Little Rock, they achieved a geometric length of stay variance, which was down to 0.2 days, which is the lowest they saw since pre-COVID. Their length of stay has gone down by 8% just in that 1 month. Transfer center acceptance has been up or increased by 60%. The Little Rock variance, which is their large level 1 trauma, was also down on their variance, down to 1.5 days. Their boarding time for their level 1 trauma center was down 12%. And the discharge home with no needs was down an overall average of 4 hours across both hospitals. So as you can see, you can drive these outcomes very quickly, and looking forward to working with them on many more projects in the future. I'm going to turn it back over to Jason, and he's going to talk to you about how we take this and move this to the next step with the next opportunities for Baptist or other clients.
Thanks, Bill. I think it's really important to just recognize the fact that, this is a client that really in this calendar year has been mobilizing their strategy, and the technology went live obviously in the last 60 days. The reality of this command center strategy, it is a journey, right? And it's a journey of connecting patient flow, one flow at a time. And you can see that, it's inside of Baptist, it already yielded very, very strong results. But we never go away as a team. Bill and his team of experts continue to work with the organization throughout their life of their relationship with LeanTaaS. And we really keep following the same, 4 steps over and over again as we optimize and connect patient flow from both a system and local level. What's the scenario we want to improve? What's the desired workflow? Who do we want to connect at very specific times? Is it, somebody at a system level? Is it somebody at a local level? Or is it both? Bill gave a great example where the escalation path actually went both through the local hospital and then also up to the command center. And once we define that, standard operating procedure, we can operationalize the improvement. And then as you can see in 30, 45, 60 days, we can see actual KPI improvement over and over and over again. And those KPIs will change. Discharges going home with no needs was Bill's example. Obviously, there will be different, efficiency metrics that we'll look at later on. One great example of, kind of a nuanced use case that can yield high results is clients go on this journey, and we see clients going through this, not only even in year 1, but year 2, year 3 of their relationship with us. They continue to find new flows that can be optimized. The one I have here is outpatient testing candidates, where they're looking for a very specific population inside of the organization. If we have Medicare patients that are predicted to have a missing test, let us know. And those candidates can be reviewed by the case management team. And if they're candidates for outpatient testing, we can remove that barrier, get the outpatient test scheduled, and plan the early discharge. So this is a beautiful example for 2 reasons. One, we are removing a potential delay that isn't even known yet in this example, right? So that patient can clearly go out the door. But we're also creating a return visit to the health system by scheduling the outpatient test as well. So a really a win-win situation for both the patient and the health system as you look at this process. And as you continue to think and you listen to us talk, I'm sure everyone could come up with their own examples inside of their health system that would be great to optimize and help them automate inside of your health system. Now, with that, we hope that everyone has heard today that we are an organization that lives and breathes the topics that we talked about today. We have many great successes across different organizations. we have a great team that would love to partner with you and share more of our thoughts on how everyone can move to next level performance. The second thing to take away is the ROI opportunity for any health system is truly massive. When you think about some of the KPIs that we've talked about today, length of stay, our nursing coverage, KPIs, also volumes for the organization. We're talking not only about potentially millions of dollars, but tens of millions of dollars of value inside of an organization. And then finally, what you'll see today is, and you'll walk away with, is the fact that the automation, the predictive and automated technology that we showed you today is an absolute requirement to create sustainable change. One of the things, if you could visualize in your own mind, since I don't have it in front of me, is, the thing that wrecks every organization is variability. And, the highs and lows of performance. 1 minute we discharge a patient in an hour, the next minute we discharge a patient in 7 hours. The next one goes out in 4, then one goes out in 30 minutes, then one goes out in 10. That variability in any process, it's not just that simple discharge process example, is what drives us to suboptimal performance. The digital technologies, the proactive technologies that we've highlighted today, reduce the variability inside of the organization. It's highly unique and it's highly scalable. And, I honestly don't believe you'll find anybody else in the world that offers the tools that we offer. So with that, I'd love to open it up, see if there are any questions that Bill and I could help out with.
Sure, just taking a look at the Q&A. Looks like we have a couple of questions that have been submitted. This first one here says, these early results for Baptist are phenomenal. Could you expand a little bit on how you go about getting early results for your clients, and are these early results typical?
I would say that the early results are typical, and it's because of the process that we go through. Patient flow, if we stay at a macro level, can seem overwhelming. One of the things that we do as a team is we prioritize the highest value flows, both first by assessing the organization, so we have a detailed discovery and assessment process, but then by meeting with the governance team and deciding what the low-hanging fruit is early on. And that's exactly why, you saw in the Baptist Arkansas, as we went, after not just discharges, but very specific discharges home with no needs, ones that were candidates for the discharge lounge, which generally is underutilized in many organizations. And we were able, by being very sharp and prescriptive, we're able to drive quick time to value.
The next question I have here is, how can organizations go about getting buy-in from across their teams for a process like this?
Bill, do you want to take that one? Because I think it's great to hear from you, because not only you can speak not only from a vendor perspective, but you've been in the health system to get buy-in. I think you'd be a great person to answer.
Sure. So I think it's a couple different ways, David. One is getting not only senior leadership to share their vision and talk about what their kind of vision is for the organization, not just, the next 90 days, but the next year, 3 years, 5 years. As Jason mentioned, this is a journey. Patient flow is not something that happens overnight. So that's the first step, is to share that vision. And then as Jason just mentioned, this is also working down into the organization so that not only, the nursing units, the EVS, transport, food service, everyone understands their role into the process and has a part of it, and they understand what their part is. Patient flow is a daily opportunity. From a command center perspective, many times that I've run those command centers, it takes a daily management and daily observation, looking at the KPIs and holding standard to those standard operating procedures and those processes. And it takes the organization to run forward all together to be successful.
Awesome. And then I have another question here. What is the average time / staff commitment that is needed from the hospital side to make this transformation a success? And with that, does the size of the organization affect timelines in any way?
So, from a timeline, so just to kind of break down a few things, to go from kickoff to mobilization, right? First, and that really means like first process improvement, first measurable improvement. you're generally looking at about 4 months to go live, from kickoff to go live. Now, inside of that time frame, that is the time period where you will have IT resource commitments for data integration, and you'll have a program team that, and there's 2 levels of mobilization that you have to consider to do this the right way. The one is the governance team that we talk to. They need to be willing to commit to, the time horizons and meetings that Bill talked about, and even to go back on the previous question, you need executive commitment that patient flow is a top priority. If they're not willing to put time to it, the project will be a struggle. But then once you get beyond that, that first, I'll call it 60 days to go live, where the governance team is a little heavy and we're really, mobilizing the organization, it becomes organic. Because we never go away, it's just about prioritizing and optimizing the next flow. And that's where it begins to just kind of fold into your daily committees, or I shouldn't say daily, but your traditional committees and other activities that you follow as an organization.
Then we have another question in here. What are some of the common issues you see organizations run into while they're undergoing this transformation?
That's a good one. Bill, you want to give a couple, and then I'll give a couple.
Sure. I think from a go live and transition standpoint, it's a cultural transformation, and culture is a series of behaviors. So it takes time to change those behaviors, and it's not going to happen overnight. It's going to take weeks, months, or even years to get to being a top 10 performing health system. So I think just understanding that it's going to take time and having perseverance to work through it and focus on that vision that Jason talked about, on achieving those patient flow goals and ensuring that the patients get the care they need, is definitely an opportunity and a focus, especially when we're building out that governance and kind of setting that vision for the next steps.
Yeah, I think the one thing to add to what, Bill just said, that because, it is cultural change and you have very new ways of working that you're introducing to the organization. One thing that we see a lot of, and we're actually, working on formalizing as an organization, is the connectedness across clients to kind of understand how they want to change, what they want to prioritize, how they want to operate. So it's not uncommon for us to see, a hospital in one state, which, out west could be talking to somebody in Florida, could be talking to somebody at north. And it's really a sense of community to understand how to break through those barriers and know, and also know where people have had successes, so they really understand that the juice is worth the squeeze. And obviously we're here to have that, but it's always great to hear from your peers at other organizations.
And then this last question here, you mentioned a few times about how LeanTaaS never goes away. Could you talk a little bit more into the detail about what steps are also taken to help ensure long-term success for organizations?
Sure. So I think one thing you have to understand too, there's kind of 2 levels of success. Like first, the what you view today is actually very high-end technology. So on the technical front, all the automations, the data quality, the prediction quality, et cetera, is all automated and monitored, 365 days a year by LeanTaaS. So your quality control system inside of your health system is constantly living, breathing, and being managed by our teams. So that actually makes sure that you're making decisions on great information, all the time. Beyond that, when you think about Bill and his team and how they get mobilized inside of it, there's a structure that, we will follow. The governance structure never fully goes away. There's still bi-weekly meetings to prioritize. Every client has a prioritized list of, initiatives and other priorities. So we are knocking off the latest and greatest opportunities inside of the health system. And those tools really allow for, not only great collaboration between LeanTaaS and our clients, but they also force prioritization discussions where, any health system, we can't do everything at once, right? As a health system. So it forces prioritization, which is great because we go after the highest value things over and over again together throughout that partnership. Bill, would you add anything else? I mean, you are the guy that runs the team, so be great to hear from you.
Yeah, and the other piece I think I would add to that, Jason, is during the process, we have somebody who's assigned to your account, and they will stay with you during implementation and even post-implementation, so that you have a direct contact. So when you come up with a new idea, like you saw with the MRIs, you can reach out to them. They work with you. They build out the work processes. They build the template. They build the workflows. So you have somebody that's at your side going forward. And then we also set up a routine structure. So, a monthly meeting, and then we also do executive business reviews. So we'll come back on a consistent basis and review KPIs, where you're at, what we talked about. And then we learn as the organization changes, we build those changes with you. So if something changes and you want to focus on throughput or access with your transfer center, we then continue those conversations going forward.
Yeah, the one I'll put the cherry on top, I guess. The one thing to also consider is the fact that patient flow is a very diverse, topic, with many topics within it. So it's not uncommon for, one of our leaders who's running an account to pull in other team members dependent on the topic. So, we have, physicians within our team, nurses within our team, workforce management experts, et cetera. So depending on the topic and the area of initiative, you actually get much more access than one individual. You have an entire team of experts that may be pulled in dependent on topic.
Very true.
And I think those are all the questions that we have for right now. Thank you all for joining us today. We truly appreciate your great questions and engagement during the session. We would also like to thank our speakers, Jason and Bill, for taking the time to chat with us. As a reminder, please check out the resources section on your console and complete the survey when you get a chance. Have a great day.